Hello, my name is Maria Fernanda Lorenzo-Gomez and I am professor in the Department of Surgery at the University Hospital of Salamanca, located in Salamanca, Spain. On behalf of my co-authors, I am happy to present our work regarding the influence of the clinical profile of patients in the need for pelvic floor physiotherapy after the surgical treatment of stress urinary incontinence during the first ever ICS online meeting. The presenter does not have any conflict of interest to declare. Pelvic floor muscle training is the first line treatment for stress urinary incontinence, but it also may be necessary after surgical treatment of stress urinary incontinence. We try to determine which profile of patients are most likely to need physiotherapy after surgical treatment. However, it can also be diagnosed as an iatrogenic situation after surgery or radiation therapy in both men and women, leading to renal dysfunction, urinary tract infections, and pain. The objective of this study are to identify the profile of female patients who need adjuvant pelvic floor muscle training after stress urinary incontinence surgical correction and to report the results of this technique. We underwent a retrospective study of 160 women treated with pelvic floor muscle training after stress urinary incontinence surgical correction. The patients were grouped according to the correction technique, differentiating patients underwent transobturator suburetral sling surgery, adjustable suburetral sling device implantation, and simultaneous correction of cystocele and stress urinary incontinence. The variables studied were age, body mass index, secondary diagnosis or concomitant disease, including surgical background, ASA score, treatment efficacy, and number of pelvic floor muscle training sessions. The results were: mean age at the general sample was 62 years, with a range between 38 and 92 years, being younger the patients in group 1. There were no significant differences in the body mass index between groups. Patients received a median of 20 pelvic floor muscle training sessions independently of the previous anti-stress urinary incontinence treatment undergone. 95% of patients in the TOT and simultaneous cystocele repair plus TOT did not have any toxic habit compared to 81% of patients in the REMIS group. Active smoking and other toxics like alcohol consumption were present in the REMIS group, 18 and 90% respectively. Having no toxic habits was more frequent in those patients with better outcomes than in those who failed after pelvic floor muscle training. Patients with partial improvement after pelvic floor muscle training received the lowest number of sessions. According to the previous anti-incontinence surgery performed, patients with TOT and partial improvement after physiotherapy received fewer sessions. No differences were found in REMIS and simultaneous TOT and cystocele repair patients. Autopsy deliveries were more frequent in the successful physiotherapy group after TOT, and hysterectomy was more frequent in the successful group after cystocele plus TOT. 55% of patients in the successful group after TOT did not have any gynecological anesthetic background, towards a 36% in the cystocele plus TOT group. On the bottom of this slide, you can find the information about the ASA score in the general sample and according to the previous stress urinary incontinence surgery performed. ASA score 2 patients were more frequent in the general sample. ASA score 1 patients were more frequent in group 1 than compared with group 2 and group 3. At the top of this slide, the three graphs show the distribution of the ASA scores depending on the results of the pelvic floor muscle training protocol. ASA score 3 patients were more common in the failed group of patients who underwent cystocell repair plus TOT, and no subself patient in this group had ASA score 3. On the other hand, 22% of successful patients who underwent REMIS had ASA 3. We conclude that patients in the TOT group were younger, have a lower ASA score, and fewer gynecological disorder, being these variables comparable in both groups of patients with REMIS and simultaneous correction of cystocell and TOT. Patients with ASA score 3 have the worst outcomes with pelvic floor muscle training. Thank you very much for your attention.